Good afternoon, and thank you for organizing this talk for me. Most of the work that I'll be presenting today has been done together with the Israel Center for the Treatment of Psychotrauma and the Hebrew University of Jerusalem. I'll be describing the journey we did with trauma research and resilience research in Israel and the treatment of traumatized children. I will briefly present the impact of trauma of war and terrorism in children, then describe our project on school-based screening and interventions and the research done, then move to earlier age, to early childhood, and present relational PTSD and early childhood research, and focus a little bit on the constructs of cumulative trauma, allostatic loaded survival mode, and conclude with the description of the essential continuity of services for traumatized children from trauma-informed perspective. So the American Psychological Association defined trauma as an emotional response to a terrible event like accident, rape, or natural disaster. We can add war and terrorism. They acknowledge that immediately after the event, shock and denial are typical. There are normal responses to abnormal events. But the longer-term reaction include unpredictable emotion, flashbacks, strained relationship, and physical symptoms, and that compose PTSD. When we deal with the term psychological trauma, sometimes we address the traumatic event. Other times we refer to the coping process or the meaning assigned to the traumatic event, or explore the short-term results or long-term consequences. In this presentation, I will focus on the impact of trauma, and as it was described by Judith Herman in her seminal book, Trauma and Recovery, traumatic events overwhelm the usual methods of coping that give people a sense of control, connection, and meaning. I was asked to just give a brief introduction on trauma, and there are related constructs which need to be explained first. What are the normal reactions to trauma? What is resilience, survival mode, and long-term consequences for cumulative trauma, and last and not least, post-traumatic growth. So I brought you a short metaphor of the normal coping with traumatic event. And our memory is full of memories, from good and bad memories that combine our memory book. And then when trauma strikes, it takes all the screen, all our attention. We're unable to think about anything else. And it takes some time till the process of normal recovery happens, and gradually the trauma is processed and elaborated and gets smaller, and it's not forget, but it lets room to other memories and our other functioning to be present. And that's the normal processing of trauma. And the path of illness and psychopathology, or what we call PTSD, is when the trauma remain present and people are stuck in the trauma, as if there is only one date in the calendar when the trauma happened, and it doesn't enable them to focus on other events or other functioning. That's the meaning or the toll or the everyday toll that people with PTSD pay. So let me just focus a minute on the normal arousal level that occur between the higher and lowest threshold. When trauma strikes, it breaks either the upper threshold or the lower threshold. And in essence, the process of trauma treatment is the effort to bring back the patient to the normal window of tolerance of arousal, that within this window of tolerance, you can process a trauma and you can administer treatment. If the person is hyper-aroused or hyper-aroused, is unavailable and not engaged in treatment. Last, the PTSD is defined by 5 clusters of re-experiencing the event, such as memories and flashbacks, avoiding the stimuli connected to the traumatic event, which can be avoiding physical places that the trauma is connected, or memories of the trauma, symptoms of hyperarousal or hypoarousal, changes in cognition and emotions such as excessive blame or blaming others, or inability to remember key features of this trauma. And most of all, it impaired functioning. That's what it means to suffer from PTSD, impaired functioning in learning and social and family function. So there are lots of research, and I just bring one famous meta-analysis by Emily Ozer. They try to predict which are the risk factors to develop PTSD after exposure to trauma, because we know that only a minority will develop PTSD, and they identified, based on a large number of studies and participants, several risk factors, such as prior exposure to trauma, prior problems in adjustment, family history of psychopathology, the level of perceived threat during the trauma, lack of social support, and peri-traumatic emotional responses and dissociation. It's important to highlight that there are multiple post-trauma adaptations. Not all people who are exposed to trauma develop PTSD, actually the minority. The majority are resilient, but they can develop PTSD in delay, or they can suffer from several post-trauma adaptation trajectory. I will move now to the 9/11 trauma in New York that we learned a lot from the effort done in New York and brought it to Israel and translated to our culture and our context. And I'll share with you what are the lessons learned and how we implemented research and project in Israel. So what we learned from the trauma of 9/11, that there was a big survey in New York, 6 months after 9/11, done by Christina Hoven from Columbia University. And they screened a large sample of school children in New York. They found a certain percentage of PTSD, but the most interesting finding that attracted our attention was that 2/3 of the children that were eventually identified with post-traumatic stress disorder were not identified by the school personnel and were not referred within the school system or mental health professional to treatment. So the lesson was that if you want to help children and traumatized children, you have to reach them out. They are not referring to services. And that led us in our context. This is bringing you to the Israeli context with recurrent terrorist suicide bombing in restaurants and buses, and in addition to wars and recurrent wars. And we first searched the literature, what can be done in terms of post-disaster and post-mass disaster, such terrorism and war, and how we can help the children in doing school screening and intervention. And there are many publications about school-based screening in the context of natural disaster, in the context of the war in Bosnia, after terrorist attack in Oklahoma, Kenya, Tanzania, and even in the context of inner violence in Los Angeles. Why did we choose as a first response to mass trauma to implement school-based screening? Because this is a way to reach out to children in their natural environment with no stigma. It's a cost-effective way, And it's identified children who may suffer in silence, and as we learned, are not identified by their parents or teachers. And it should be as part of a more comprehensive system of care within the school system and community. We focus on school-based screening and intervention because trauma interrupts the school routine, and traumatized children has been shown to have lower grade point average. They have more reports from school, more difficulties in concentration as part of their post-traumatic symptoms, and more aggressive behavior. So what did we screen for? We screen for exposure to trauma. We screen for post-traumatic symptoms that we adapted and adjusted to our context. We screen for functional impairment in academic studying, social behavior, and family functioning. And we assess depression and somatic complaint, which is very common among children. And later, we added to the risk factors the assessment of protective factors in order to get a more comprehensive picture, such as social support, self-efficacy, ego resilience, flexibility, optimism, and some more. And that's one major lesson we learned, that we need to look at the big picture of risk and protective factors in order to identify the children that are in need of services. It's important to emphasize that the school-based screening should be part of a more comprehensive program, ecological model. We need to start with training the teachers before we screen children. We conduct parents' meeting and explain them and give them psychoeducation. Then we screen the children, and after we identify distress, we need to have intervention ready for them. For those who are traumatized, we have more intensive module of intervention. And for those who are anxious, maybe building resilience intervention would be sufficient. We publish it in several papers that appear below. I just want to share with you a description that I got from Marlene Wong in Los Angeles in the context of inner city violence, how if we train the teachers and the parents, they are more attentive, more sensitive, have a more musical ear to listen to the traumatic content in the story of children. And let me share with you this vignette of a sixth grader saying, one night several years ago, I saw men shooting. This is the exposure to them, at each other, people running to hide. I was scared and I thought I was going to die. After this happened, I started to have nightmares. I felt scared all the time. I couldn't concentrate. So we hear the post-traumatic symptoms. I thought that something bad could happen to me before short-term future is one aspect of PTSD. And then I started to get in a lot of fights in school with my brother. So moving back to Israel, when we conducted a large-scale screening, we found that about half of the students were not directly exposed, but 28% were directly exposed to violent attack, missile attacks, or any other terrorist attack. And about 18% were indirectly exposed. And those who are indirectly exposed constitute a vulnerable population as well. It's the near-miss experience. It could have happened to me. It didn't, but it could. And it can happen to me in the future, as we can see in the following voice of a non-exposed adolescent that we identified as suffering from PTSD. And the school said, no, he didn't have any traumatic event. He wasn't exposed. But when we interviewed him, we heard from him that his mother was driving his car when the bus next to her exploded. His father was on his way to lunch in a pizzeria that was bombed just a few minutes before he arrived. His cousin boyfriend was killed in a suicide bombing at the city center. A rocket fell in the courtyard of his junior high school. And for months, he was exposed to sharpshooters and rocket launcher and lived in a main road that led to a major hospital, constantly hears the sirens. He was not directly exposed, but he felt, and he as if knew that he's going to be next. So these unexposed adolescents sometimes need help as well. In large, we found PTSD among less than 7% of the students, and additional related distress of depression in about 5%. Altogether, with depression, it's the minority of students. I should highlight that 82, more than 80% are doing well despite of traumatic exposure. And this is what is called resilience. And resilience, as Ann Mason coined so talentfully, is the ordinary magic. It's more common than uncommon. People are able to cope with traumatic circumstances using their social support and adaptive coping, and just a minority develop PTSD, but it can be a big minority that need our services. This is kind of a busy slide, but the idea is to show that about 70% of the children did report on fear, but subjective fear, which can be very objective, is not PTSD. Only the minority develop PTSD. And in terms of gender differences, we know that female complain more than male, but in our study, we found that females, the girls, complain more on symptoms, on emotional symptoms, but the boys manifested their PTSD in a different way, in behavioral problems, in aggressive behavior, in impulsive behavior. So it's not that the girls suffer more PTSD than boys, but there are different ways of manifesting the distress according to gender. So we shouldn't undermine the distress of the boys. And girls simply are more open to complain about depression, about somatic complaint than boys, but boys show it differently. So we published this in several papers on symptoms and risk factors. Now we move to further questions that arose during the study. What about the strategy of maintaining the routine? What do we need to advise this youth? Should they keep on going despite the threat? And we conducted a study where we compared 3 groups of adolescents, those who avoid the places where a bomb exploded and avoid the activities that may take place near the place, those who rush despite to the place where a bomb went off as if looking for action and excitement, and those who simply stick on their daily routine. If they need to be there, they will keep on going. And what we found in this research that supported the clinician recommendation that those who kept the daily routine, despite everything, that was the best strategy to reduce anxiety and to keep on functioning. And we keep on recommending it. Avoidance doesn't work. And the worst reaction was by those who were looking for action, looking for reenactment of the fear and excitement by looking for danger. That led us to another research question. We were asking ourselves, is trauma and risk-taking behavior linked? And looking at the accumulating data, that there was an evidence of increased substance abuse, violence, reckless driving, and other risk-taking behavior among Israeli adolescents in that context of exposure to recurrent terrorism, raised the question, does the exposure to ongoing terrorism influence risk-taking behavior? So we did another study about this, and I must say that people didn't believe us that we will obtain sincere responses from the adolescent. We asked them, do you drink and drive? Do you practice unsafe sex? And they did answer. And we were able to obtain these answers. And of course, it was anonymously, but they were relieved that somebody is asking them, is interested in this. And there are theoretical perspectives on this, that risk-taking behavior is very characteristic of adolescent years. But in terms of the link to trauma, those who are traumatized may search for re-experience the trauma through reenactment of the threat, or it may change their perception of the world, that the world is unsafe anyway, so risks are negligible. Or it will lead to a state of chronic hyperarousal that are pushing them to more activity and hyperarousal. Or it may be, we didn't believe it, but we found it, a cry for help by this adolescent. So here are the results. And in big numbers are the rate or the percentage of risk-taking behavior practiced by those youth who were not only exposed to traumatic events, because everybody were exposed, but developed post-traumatic symptoms. So we found that actually those youth who were traumatized practiced twice as much drugs, unprotected sex, drinking alcohol, dangerous game roulettes, and almost all risk-taking behavior. That is, adolescents do tend to try risk-taking behavior, but the traumatized adolescents do it twice as much. We published it in the American Journal of Psychiatry with the conclusion that if you see traumatized youth, you should ask about risk-taking behavior. And if you see a group of youngsters practicing risk-taking behavior, you may inquire about trauma or post-trauma because they are so linked together. In their own words, if we listen to the adolescent, they say, well, we don't know what is dangerous and not dangerous. What seemed to be not dangerous, taking a bus to school, can end up deadly, right? So we can smoke drugs and we don't die from it. And life is short anyway, why not taking chances? Please regress to your adolescent thinking and language so you may understand these sentences, or kind of regaining control by saying, I will decide if I die or not, and what will happen to my life, and they will not decide for me. If I die, I choose it. Ring a bell of adolescent thinking. The next question that we asked ourselves was, well, do the children and adolescents know when they need help? And do they seek help? That's a major issue. And we could conduct an analysis on existing data that we had on lots of screening measures, just looking at the one question that we included, do you need help? And we had three options presented to the adolescent. Yes, I do need help. I'm not sure I need help, which is in adolescent language. Yes, I do need help. And no, I don't need help. And let me just focus on this group of youth with clinical PTSD. Over 55% simply simply said, yes, I do need help. And if we add another 17% that say, well, maybe I do, we see that almost 3/4 of the children of an adolescent know when they need help. So if we don't have resources, we simply can ask the youth, do you need help? And probably many of those who need help will ask for help. We continue to look for more protective factors, not just risk factors. And we tested the role of self-efficacy and coping strategies, flexibility. Can it help children and youth cope better with the traumatic circumstances? And we know from the literature that social support is the central protective factors, and seeking help, we already mentioned, and maintaining routine. And there are many other protective factors that can be explored, such as altruism, optimism. In this paper here, we tested an alternative model for screening, not to screen for risk factors, but to screen for protective factors. And maybe those youth who have been identified with low-level protective factors, these are the adolescents who need more help, not just by risk factors. And as we learn more, we understand that a comprehensive picture of both risk and protective factors provide the best assessment of the distress and the need of help. We then move, and I'll soon conclude with the school-based intervention, to understanding that in order to implement effective school-based intervention, we need to implement a city-wide approach, speaking the language of resilience, not only with teachers and parents, but with first responders and medics and physicians and nurses and firefighters. They should understand what are the normal responses to trauma, who are affected, who are at risk, who is at risk, what are the abnormal responses that need help. And we published this chapter on the city-wide approach, and there we describe actually a control study of schools. We started a school-based screening in a city, a mixed city of Arab and Jews in the northern country, in the north of the country. And then after we started training the teacher, riots happened. At first we thought, oh, our study is done. But then we understood that actually we can compare those schools that we trained the teachers with other schools that we didn't train the teachers. And we measured the children in both schools because we planned on, it was on waiting list to train the teachers. And we could find that those schools that we trained the teachers, the level of symptoms among the children were lower, significantly lower. And why was that? Because the teachers knew what to do. And after the riots happened, they called up the children, invited them to school, and did some intervention to process their fear, to explain the normal reaction, to get support, to get reliable information. So these children in the school where their teachers were trained and knowledgeable were less distressed than in schools where their teachers were not trained. So that's an example that we should implement a larger approach of schools, and the entire city should be involved. Last, we are aware that this is now the technological frontier, and we need to develop services through applications and cell phones. And this is the future. And there are attempts now to adopt trauma treatment, information, exercises, increase social support, sharing, narratives, etc., through the application of cell phone. I will now move to early childhood. And the reason I moved to early childhood is because this field is neglected. People are less aware the young children can be affected by trauma. And I like to present our studies, research, both research and practice on early childhood work with parents and and young children. First, I always ask my student, is young age a risk factor or protective factor for long-term effect of trauma in children? And usually the response is half and half. And the reason are that maybe young children do not understand the consequences of what's going on, and that can protect them. So I'd like to make a disclosure. I'm going to try to convince you that early age is a risk factor for developing trauma responses in children. It impacts not only the child directly, but it impacts the immediate environment of the parents by which the trauma is exacerbated for young children. So going back to the situation in Israel, this is a story that the child painted, how the missile fall, and there's ambulance and casualties, etc. And there is red color as a siren of alarm. So we started with a very simple survey among children and parents asking about their own symptoms and their children's symptoms. Of course, we cannot interview the young children. And I think this is important to start with the normal responses that the parents complained about impairment of family activities and attempts to not to think about the events. And the children suffer from all kinds of sleeping problems. They refuse to sleep alone. They wake during the night. They insist on sleeping with their parents. And this was done in southern Israel, where in an area that was exposed to recurrent missile attacks. So these are the normal responses. But yet, you can imagine what does this mean to be a parent to a child that is exposed to missiles, to recurrent missile attacks, and how difficult it is when you don't sleep at night because of the fear of the child and your own fear to separate from him. We use for this research the new alternative criteria for identifying PTSD in young children. And the criteria was developed by Michael Scheringa. He is from New Orleans, from University of New Orleans, and he did a lot of research after Hurricane Katrina in New Orleans. And he added a cluster for young children, for preschool children, that the trauma is manifested in developmental adjustment. The children tend to regress in the behavior or not to develop appropriately. There is social withdrawal, there is traumatic play patterns. So he really included clear criteria how to identify early childhood trauma. So we did it and identified children and traumatized parents. And here I'd like to share with you a big failure of us. We learned from the Americans, from the people in New York who identify young children 2 to 4 in South Manhattan near the 9/11 towers, and adopted their interview of parents. So we chose a very traumatized city next to Tel Aviv, but quite far from Tel Aviv. I mean, it's a 45 minutes drive. And we were able to go to the daycare and identify children who has PTSD in early childhood and parents who are traumatized. But then we wanted to refer them to treatment. And there were no treatment in the area. We said, okay, please travel to Tel Aviv and get some treatment. The bad news were none of the family did it. So we learned the lesson and we said, well, if we go into early childhood program again, we need to prepare a cadre of therapists in the area to create local capacity and sustainability so the family can be referred to treatment in their own neighborhood. And we did it, and I'm just telling you, 85% of the families that were identified with trauma came forward to treatment, and they were accompanied by a research assistant from the project who live in the area. So we learned that if we want to really provide services, we need to start services in the area. Let me share with you some qualitative results, because we interviewed the parents living under stress and wanted to learn some insight from their experience. And I'm bringing their voices as are. Everything changes when my child feels insecure. He doesn't play or try new things. This is how trauma in young children look like. When she hears red color again, everything freezes. She regressed back to behavior like baby, bedwetting and asking for a bottle of pasta. This fear of abandonment, it's been since the war. During the war, I never left her for a moment, except for one time when she said she wanted to go to the toilet, and I, instead of overcoming my fears and showing her who is the boy, I told her, I don't care, pee on yourself. I'm not leaving this shelter. I did some terrible damage, irreversible damage to my children during the war, and see the result. I see how he's afraid of every little noise. I myself am a coward. What can I do? It is out of my hands. There are situations when I can tell them, don't be afraid, but in other times, I feel powerless. Well, guilty parents, guilty parents is not good for any child, is it? At the moment, I felt as if I was a child, like her. Like, what do we do? Where is our security? Where? But wait, I'm the mother. I should show her. My head was so confused. I felt like her. I felt like she should be the mother. And we see role reversal under such traumatic circumstances. What about guilt? This is a narrative of a father who says, I feel wrong as a parent that I expose my children to such a dangerous place. I feel pain and sadness, that he's afraid and that he's going through his childhood in fear, and not like the other children in Tel Aviv. It hurts that you cannot raise your children in a normal environment. So frustrating that economically, I cannot take the family, convince my wife to go to a safer place where he can go and whenever he wants, and I limit his childhood. This is not simple, because these parents tend to either not keep their limits on the children and provide too many sweets as compensation, or these parents allow them all kind of behavior just to discharge and can be very risky. And last, she's much more empathetic to other people's pain for a young age. She might have lost some of her childhood, however, she also acquired something meaningful. I don't think it would have happened had she not been through the constant 4-year-old girl to have post-traumatic growth. We want a normal childhood. I want her forward. So I'm moving now to the concept of relational PTSD, which means that the distress co-occur in parent and child, and usually it is transmitted from parent to child, as the caricature shows. And we know from research or from the literature and from the theory that post-traumatic symptoms and parental distress affect and is correlated, associated, linked to post-traumatic symptoms of the children. We know this correlation, but we are more interested in the mechanism and the path by which the parental distress affects the child distress. And it can go through the attachment, impaired attachment as a result of trauma, or impaired reflective functioning, or parental attunement. How can you be attuned if you have 4 children and you need to run to shelter, and it impairs parental competence? In our research, we focused on parental emotion regulation because it's so central and because it can be changed, it can be enhanced, it can be taught. So emotional regulation is not only relevant to trauma, but it can mitigate the impact of the parental distress on child distress, or what we call intergenerational transmission of distress, and it can be relevant to a variety of clinical intervention. Let me walk you through this slide that show how the parent, in this case, the mother, needs first to regulate herself, kind of an internal process, before she's able to regulate or co-regulate her child, which for the child, it's kind of an external process. And then the child learns to regulate himself or herself and learn to do it internally. What happened when trauma strikes? It impairs the ability of the mother to regulate herself. She may suffer from post-traumatic symptoms that impair her ability to regulate. Then she's less able to co-regulate the child. They have sensitivity, attunement, reflective functioning, mentalization, modeling, etc. And then the child may suffer from more symptoms because he's not co-regulated optimally. And that would add an extra load on the mother who is coping with her own distress. And that's the process of co-regulation. And that's why we implemented in our studies and project enhancement of maternal emotion regulation. I just briefly show you a questionnaire by which we assessed. How do we assess maternal emotional regulation? And there are various aspects of, for example, non-acceptance of emotional response. For example, when I'm upset, I feel guilty for feeling that way, or limit access to emotional regulation strategies. When I'm upset, I believe I'll end up feeling very depressed and there is nothing I can do about it. So the result of the study showed that if we look at the impact of maternal post-traumatic symptoms on the child emotional regulation problem, this impact is mediated through the maternal emotional regulation problem. And just to mention that the correlation between PTSD of the mother and emotional regulation of the mother is moderate, is 0.4. It's not that we call another name for maternal PTSD, now we use the term maternal emotional regulation. No, it's a different capacity and parental competence that can be enhanced. And indeed, we published a paper that show how we can work with improvement of emotional regulation of the mother in continuous traumatic stress. I would like to conclude with some intervention. How did we translate the knowledge gained by research and theory to practice? And we prepared intervention for parents and children, mother and children, which we term, let's make room for play. Traumatized parents play less, as if they don't have this degree of freedom. And the purpose of this project, which is our wonderful team, which I'm very grateful, was to help the parents to improve the cognitive functioning of their children through play, and to teach them play activities by which they can process the trauma and help the child regulate himself. And there were 8 meetings, dyadic meetings, in which each meeting included kind of a proverb and a theme that we process in terms of psychoeducation, then we practice an exercise, then we learn the lesson, and the mothers learned how important it is to have exclusive time with the child, how to protect the child, how to let him play and not to be overprotective, how to let him or her express her feeling, and what is typical for trauma play, which tend to be rigid and repetitive, and how you can help the child get out of this traumatic play. It takes a village to raise a child. That lesson we agree totally. And I would like to conclude with the comments that children are particularly vulnerable when they are exposed to war and terrorism, not less vulnerable. And there is a need in sustainable program and building local capacity. If I have 2 more minutes, I would like to mention that we should look at chronic or cumulative stress and explore the allostatic load versus habituation model, namely, does continuous exposure to trauma increase vulnerability and increase distress, or people tend to be habituated? They are used to, and many people think so. You get used to. No, our results show the opposite, that continuous traumatic stress and allostatic load is more detrimental for development and behavior. And just one slide on longitudinal follow-up that we did. We assessed the children in 2004 when they were 2 to 4. Then we came back to long-term follow-up after 7 years, wanted to know what happened with early childhood trauma. Do they grow out of it? And not just explain this. We found 40% of the children with distress in a highly traumatized setting. About a third recovered, but 2/3 continue to be distressed. That means you need to continue with services and maybe more effective services. With regard to the resilience, those who were resilient, majority, above 60% remained resilient after 7 years, even though they were continually exposed. Yet, about a third do develop symptoms. So we have to be very careful when we assess them over time. And there is a need in longitudinal research on all levels. We did not discuss the impact of the trauma on the body. We did not discuss the role of the father and many other protective factors and what we call post-traumatic growth that can be saved for other presentation. I just conclude with the message of resilience, which is more common than uncommon and relevant to many different contexts. And if I may, I'd like to thank you. And if I may, I can read a poem written. Can I? All right. So there is a poem by a resilient child that we adults should learn from her. So I thank you very much for your attention.